Good afternoon, colleagues, and welcome to this afternoon's deep dive, which is a special one as it's the last one for 2021. And I think you'll all agree with me that we look back on a phenomenal year that I think was really very successful, with fantastic speakers and talks from literally all the universities. And I must say, I'm very excited to see where this is going to go in the future. I think one of the good things of COVID, at least, has been the ability to come together on a regular basis virtually. And I think the deep dive has been a good example that we can really do high-level academic teaching, even though we can't necessarily be together. So I'd just like to start today by saying a huge thank you to everyone from every university, every head of division, every registrar, fellow, senior registrar, whoever has been involved in making the year a success. I have learned a huge amount, and I'm sure many others have had the same. And from the feedback we've received, this has really been one fantastic journey. Now, for those of you who might be here for the first time, we just like to say welcome. Nice to have you here, and you will be very welcome next year again. This is our last session for 2021, but we'll resume in January. And you're welcome to invite any friends. We've got lots of space on Zoom, and so don't worry about sharing the invitation. These sessions are CPD accredited, but I also want to just say that the CPD processing is still done manually by our team at UCT. So if you need CPD points, then please email Melanie Davids. We'll put her email address in the chat box just now. Email her to ask for your CPD points for the past year, and she will get it all together and send you the certificate. The second thing is to register for CPD points happens on an individual basis with every session you attend. And typically at the top of the hour, we will add a link to the chat box with a code that you click on the link, and then you're going to fill in your details plus that code. It's usually a number, and then just register your attendance, and based on that you are registered as having been present, and then you will qualify for CPD. We also record these sessions, so if there are sessions that anybody needs to watch again, want to review, prepare for exams, then you can also go to the links for that. If you don't know what the links are, you can just email Melanie. She can guide you to the right place. So without further ado, the last session for 2021 is going to be on rare cases of NKT cell non-Hodgkin's lymphoma. Certainly a topic important to know about, but not encountered every day. And we're very happy to welcome Dr. Venita Phillip today, who's a senior consultant clinical hematologist at Chris Hani Baragwanath Hospital, and who is also a frequent organizer of exams and a senior examiner in the exams, both in HemPath and ClinHem side. So I suggest that all the trainees listen carefully to what Venita and her team has to say. And I'm very thankful, Venita, that you've agreed to co-chair the session this afternoon. And I will leave the introduction to your team and the talks to you. So with that, again, big welcome, everyone. Welcome, Venita. I'm handing over to you, and you're welcome to share your screen.
Thank you, Vernon, for those words. Thank you to everybody for joining us for the last meeting of the year. I think we are keeping you away from Christmas if we are the last session. I'd like to go ahead, and the first speaker today will be Dr. Matlatsi Mankwele. Mankele, sorry, who is going to talk to us on a visitor from the East and South Americas. And he is currently a medical registrar in his third year in the vet circuit. And I wish him all the best. You can go ahead, Matlatsi.
Good afternoon, everyone. Thank you, Prof. Lo. Thank you, Dr. Philip, for the introduction. It's the that's how my surname is pronounced. All right. All right. Let me just share my screen.
My apologies.
No, I'm just pulling your leg, Dr. Philip. Share. Okay. All right. As the topic of today's talks has been introduced already, it's on rare cases of NKT cell non-Hodgkin lymphoma. I'm Dr. Mangela. I'll be presenting with one of the fellows in the department, Dr. Kwetwana. The World Health Organization revised its classification of mature T and natural killer T cell lymphomas in 2017. And the focus of my talk specifically is on the extranodal NKT cell lymphoma nasal subtype. So my title, again, it's basically from the East Americas, and it will be unveiled why I've called this particular case a visitor as the presentation goes along. These are the contents of my presentation. All right, let's get into it. Okay, so present the case. Our patient was Mr. NK, who was an Afro-African male residing in a township in the south of Johannesburg, South Africa. He was negative for HIV. He presented to his primary healthcare facility with a 1-week duration of bilateral nasal congestion, as well as a 6-month history of headache, where he was assessed as having sinusitis. He was treated with a short course of antibiotics and antihistamine. However, he did not respond to this treatment. Over the next few weeks, he had right facial swelling, bilateral purulent nasal discharge, and a loss of vision in his right eye. In addition, he also had B symptoms in the form of weight loss and drenching night sweats. He does not report any peripheral lumps. He does not report abdominal swelling. He was ultimately referred to the otorhinolaryngology department at Chris Hani Baragwanath, where he was assessed and noted to have an ulcerative necrosed lesion on the right inner cheek, which is complicated by cellulitis of his right face. He was noted to not have any Waldeyer ring lymph nodes. He was also noted to not have any other peripheral lymphadenopathy, did not have hepatosplenomegaly. However, he was noted to have this diffuse papular rash on his upper limbs. This is just a picture that we took of him on presentation. This picture showing the right fasciitis that he had. The second picture we have here was one of his right inner buccal area that's showing the ulcerative necrosed lesion that he has there. This is the initial blood workup that was done for him at the ENT department. Of note, basically, he had a WHO grade 2 leukopenia. He had a lymphopenia, which is most likely related to the EBV infection he has. He had a monocytopenia, which can arise in acute infections. Lower down there, he's got a CRP of 68. So had acute infection on board with the cellulitis. Of note, he also had a WHO grade 2 microcytic hypochromic anemia with normal hematinics. And this was most likely anemia of chronic disease, what others also name anemia of inflammation. On the bloods, we can also note that there's no evidence of tumor lysis at this point. There is a raised LDH, which is just a marker of tumor load and high cell turnover. Also of note is that it's got a raised beta-2 microglobulin. Although very non-specific, it can be raised in lymphomas. He went on to have an incisional biopsy of the lesion, which revealed a high-grade non-Hodgkin lymphoma. Immunohistochemistry was done. It was negative for ALK. It was negative for the T cell markers CD4 and 5. It was also negative for CD15. It was, however, positive for CD56 and showed membranous staining. Epstein-Barr virus in situ hybridization, short of which is IBRISH, showed nuclear staining, was positive. The tumor cells were negative for detection of clonal T cell receptor gamma chain rearrangement. A final diagnosis of nasal natural killer T cell lymphoma, standard abbreviation NKT-L, was made. A biopsy of the lesion, the skin lesions rather, did not show involvement of the skin, basically just showed a resolving lichenoid reaction. His staging CT basically showed the lesion with dimensions of 4 by 6 by 5 centimeters. There was no hepatosplenomegaly. However, of note was that there was also a left cervical lymph node at the level of C3, which measured 1.7 and 1 centimeters. There were no other lesions on the CT. This is just the CT image, again showing that right buccal area mass. This is the coronal view, another coronal view of the mass, here showing involvement of the orbit. A bone marrow was done, and this didn't show any infiltration. Of note, however, is that his EBV, IgG, and IgM were negative. His EBV PCR was done. However, there was a sample processing error rather. This would have been a very helpful result to have and see, and I'll elaborate on why that is later in the presentation. So in summary, our patient was a 39-year-old male, no known comorbidities previously well, presented with clinical and pathological features of localized NKT-L. He was assessed as being stage T4 N1 M0, making him a stage 3 with performance status ECOG 0. He was put on the SMILE regimen, which composed of dexamethasone, methotrexate, ifosfamide, Laspa, and etoposide, and was also planned for sandwich radiation therapy. All right, getting into the gist of it. Basically, viruses are oncogenic and they're responsible for 15 to 20% of all cancers in humans. Epstein-Barr virus, specifically also known as HHV8, is one of these oncogenic viruses, and it's associated with both lymphomas as well as epithelial cancers in humans. It also infects unusual targets like T lymphocytes and natural killer T cells, as per our presentation today. EBV itself is a ubiquitous virus which affects 90% of the world's population in its latent form. It is transmitted predominantly through oral secretions. There are, however, reports of it spreading through blood products and organ transplantation. The age at which primary infection occurs is influenced by developmental and socioeconomic factors, and the poor standard of living in sub-Saharan Africa results in primary infection occurring by the age of 3, while primary infection in the more developed world occurs much later in life, early adulthood. This slide basically just showing us the targets that EBV, the cells that the EBV can target, which are B cells, epithelial cells, and the unusual target, in this case, the NKT cells, and the lymphomas that can result thereof. With the slide, I'm basically just reminding everyone ontogeny of NK and T cell, that these two cells basically have a common ontogeny, and this explains the similarities in their markers. NK and T cells, because of them sharing a common ontogeny, both express CD2 and CD7. However, unlike the T cells, the NK cells are negative for the surface CD3, but they express cytoplasmic CD3. The NK cells, differing from the T cells, also express CD56, CD57, and CD16, with CD56 being the most consistently expressed. Just in terms of the actual function of natural killer cells, they're part of the immune system, and they target tumor cells and bacteria or virus-infected cells and kill them by the process of cytolysis. We're now going to go into the pathophysiology, and we'll first look at the pathophysiology of EBV oncogenesis. There's basically two EBV genotypes, which are named type 1 and type 2, and the differentiation is based on diversions in the virus nuclear proteins, the Epstein-Barr nuclear antigens, short of which is EBNAs. There's 6 EBNAs named 1, 2, 3A, 3B, 3C, and LP. These EBNAs have different biological activities in tumorigenesis. There's a variation in the EBNAs expressed in different cells, and this determines the type of latency program that the cells go into. There's 3 latency programs that the cells can go into, and again, a bit unoriginal, I just called type 1, 2, and 3. The type of latency program that the cell goes into determines the kind of malignancy that results thereof. There's geographic variation in the distribution of the EBV genotypes, with the type 1 mainly being found in South Asia, in China, Europe, and American populations, while the type 2 genotype is found predominantly in Africa. This table, quite busy, but basically showing us again those EBNAs and the latency programs that result from these EBNAs and the resultant malignancies that we get with the EBNA and the latency that the cell goes into. Of note, basically, is that the type 2 latency is the one that's involved in NKTL. So the pathophysiology of NKTL itself, like I said, it's the type 2 latency program that the cell goes into, and the result of which is constitutively activated signaling pathways, including JAK2 and NKKB, which results in promotion of cell growth and survival, as well as promoting tumor immune escape through upregulation of programmed cell death receptor 1, PD1, as well as PD-ligand 1. Also, what you get is loss of tumor suppressor genes such as ATG5, PRDM1, FOXO3, AIM1, HACE1, which results in apoptosis resistance. We're now going to look at the epidemiology of NNKTL. There's great geographic variation in NNKTL prevalence, and it predominantly affects Asia and South American population, hence the title of my talk. In these countries, 3 to 10% of their non-Hodgkin lymphomas in Asia and South America are comprised of NNKTL, whereas the composition is less than 1% in Western countries. There's great paucity of data on NNKTL in Africa. The only study, to the best of our knowledge and researches on NNKTL in Africa was a 10-year retrospective study that was done in Tunisia between 2007 and 2017. And according to their records, the prevalence of NNKTL was 0.78%. So the question really is, are we actually having low numbers of NNKTL in countries? Or is this due to paucity of the the requisite immunohistochemical and molecular diagnostic techniques, the IBRISH, that is required. We have these facilities in other African countries. This is just the paper that I was talking about, the 10-year retrospective study that was done in Tunisia. So the million-dollar question really with this case is, why do we have such low NNKTL numbers in sub-Saharan Africa? This obviously being in contrast to the EBV-associated malignancy that we have locally, the Beckett's lymphoma, which is much commoner. And this is a paper that I found that was written by Prof. Patel, Dr. Philip, and Dr. Barra team that looked at the impact of HIV on lymphoma in Africa. And it was published in 2015. And this paper basically just showing us that in contrast to the low numbers of NNKTL that we have, we've got the Beckett lymphoma and Beckett-like lymphomas that are quite common in our setting. And again, what's the explanation for this difference? The only paper that we could find, according to the best of our knowledge and searches, published locally in South Africa on NNKTL was a paper that was published in the Head and Face Medicine of 2013. It was a case from Medunsa, done by Tolo with Prof. Bida, just a case report. And they went onto the patient, and fascinating it was to find such a case in South Africa. So because of this, we are actually looking into publishing our just to add to the literature that we have locally. Still on the epidemiology. So these are some of the explanations that have been suggested for the low prevalence of NNKTL. The one is that it's been postulated that certain HLA types have the disadvantage of presenting EBV-associated proteins to T cells, similar to the HLA-B46, that is a risk factor for nasopharyngeal cancer, which is also an EBV-associated cancer. Another postulation is obviously the differences in the EBV genotypes, with one type being commoner in the South and East Americas and the one being common in Africa. Environmental factors have also been suggested to potentially play a role in this difference. There's no difference in the distribution between the genders, and the lymphoma develops between the ages of 40 to 50 years. So how these patients present, the NNKTL is known for its distinct extranodal distribution. It is initially found as a necrotic granuloma in the nasal cavity, palate or nasopharynx. The symptoms of the stage or form of the disease are nasal congestion and or bloody rhinorrhea. The other symptoms that the patients can have is fever, weight loss, a sore throat, swelling of the buccal area or orbits, and a hoarse voice. Although it's locally aggressive, it can spread to other parts of the body, commonly spreading to the skin, salivary glands, bone marrow, testes, and the gastrointestinal tract. Tumor-associated hemophagocytic lymphohistiocytosis, HLH, can also occur. In terms of the histology of NNKTL, the cells comprise a polymorphic population of small lymphocytes, eosinophils, histiocytes, and plasma cells. The tumor infiltrate is angiocentric and angioinvasive with resultant coagulative necrosis. The presence of EBV in the tumor cells is detected most reliably by in situ hybridization, IBRISH, which is a diagnostic requisite. In this slide, I'm just showing the histology. The top picture basically showing the milieu of inflammatory cells that I spoke of earlier. The bottom slide showing the CD56 staining. In terms of staging of this lymphoma, the N-arbor staging has very limited utility in the prognostication and treatment decision making in these patients. As the NNKTL is most almost exclusively extranodal, and the majority is localized at presentation, for which radiotherapy is the most important treatment, and local invasiveness is the most important prognostic factor. I found a paper that was published in the PLOS One journal in 2015, a study that was done in China that basically aimed to standardize the staging of NNKTL. And it was decided and established that the TNM staging was a better staging modality, better staging modality rather. The T part of the staging basically stages 1 to 4 as per the slide. The N part of it either stages 0, 1, or 2 based on whether there's no unilateral or bilateral involvement. This is lymph node. And the M part of it being 1 or 0, with 0 being localized disease and M1 being distant disease. And once this has been done, the patients can be put into a stage of either stage 1, 2, 3, or 4. The mimickers and differential on histology basically chronic gastropathy as well as NK cell enteropathy. In terms of how you'd work up these patients, Iperish is a diagnostic requisite. And regardless of the initial site of presentation of the patient, a nasal pen endoscopy must be performed. And this is because with the advent of PET and CT scans, it's been shown that even in patients where it appears that the disease is, the primary is not nasal, that the nasal cavity, it's actually been shown on PETs that these patients always inevitably have occult nasal activity lesions. The bone marrow examination must include an Iperish, and the suggested imaging modality is the PET-CT. However, in facilities where PET-CT is not available, CT is still an acceptable imaging modality. Of note also is that measuring the serum free circulating EBV DNA in the form of a PCR has been noted to be an accurate surrogate marker of lymphoma load, which unfortunately in our case, like I said, there was a sampling error with the sample, so we actually didn't have this result, which would have been interesting to see. We now want to look at the treatment of NNKTL. NNKTL is radiosensitive. However, recurrence is quite high when radiation is used alone. So the standard of treatment is chemoradiation. So for localized disease, it's chemoradiation, and disseminated disease, systemic chemotherapy is suggested. There's no clear evidence that giving concomitant radiotherapy and chemotherapy is necessary, as sequential chemotherapy radiation has comparable result. And as a result, sequential chemotherapy radiation therapy is the preferred treatment mode. The current treatment strategies are adopted from retrospective analysis of phase 2 studies. Of note is that anthracycline-based regimens, most popularly the CHOP regimen with radiotherapy, show unsatisfactory results due to a multi-drug resistant phenotype of NNK T cells. These are the different regimens that can be used, the DEVIC, the VIPD, the LVP, the GELOX, and the SMILE. And this diagram just nicely summarizes the algorithm in terms of how you treat these patients based on whether they have localized or disseminated disease. With the localized one, you have to decide on based on the ECOG and other factors if they are chemo fit or unfit. So if they're unfit, they would get radiation therapy. If they are fit, they would get the chemo radiation. And if it's disseminated disease, they would get the systemic chemotherapy plus minus radiation therapy. This slide looks at the different regimens that have been used and some studies that have been done on these. Just to orientate everyone, the abbreviations that are used there, the ORR is the overall response rates, the CR, the complete response, OS being overall survival, and the PFS, there's actually supposed to be DFS, which is disease-free survival, and RT being radiotherapy. And of note on this table, number one is that there's poor results with the CHOP, the anthracycline-based regimens. And then of note also is the poor response with radiation therapy alone. And the other studies basically just compared the different regimens that we have. This is for localized disease. In terms of treatment for stage 4 disease, I found a paper that looked at the SMILE regimen. It was a phase 2 study where 38 patients were treated. And these patients were put into, it was 3 categories of patients rather. This being stage 4 patients, relapse patients, as well as refractory extranodal lymphoma patients. And basically the results of this was that the overall response rate for newly diagnosed stage 4 relapse and primary refractory disease after 2 cycles of SMILE were 80%, 93%, and 25% respectively. And the corresponding complete response rates were 40, 64, and 0%. Patients with a relapse disease had the best outcomes with an overall survival of 79%. Followed by newly diagnosed stage 4 disease with an overall survival of 45% and primary refractory disease with an overall survival of 25%. In terms of stem cell transplant as a treatment modality in these patients, it's been explored. However, the data is very inconclusive at the moment and is still being studied, and bigger studies basically need to be done. In terms of novel therapies that are being explored, immune checkpoint inhibitors are being explored. If you remember that in terms of the pathophysiology of NKT, one of the mechanisms of the pathogenesis is promoting tumor immune escape through upregulation of programmed cell death receptor 1, PD1, and PD ligand 1. So because of expression of PDL1 by these cells, PD1 inhibitors are a promising therapeutic agent in these patients. The other modality that's being explored is peptide vaccines with molecular targeting therapy. So among immunotherapy, peptide vaccine is a promising treatment to target virus-associated malignancy because these types of tumors express non-self viral antigens that are not ignored by the immune system. The EBV-related proteins and cells are ideal antigens for the peptide vaccines. Kobayashi et al. Previously found an epitope peptide which could bind to the promiscuous MHC2 by computer-based peptide algorithm from EBV LMP1. Because this LMP1 epitope peptide overlaps with the HLA-A2 restricted CD8 T cell epitope, this peptide might have the ability to simultaneously induce anti-tumor CD4 and CD8 T cells against NKT cells. In terms of the outcome of our patient unfortunately succumbed to overwhelming sepsis prior to him getting a radiotherapy. So in conclusion, the early signs of NKTL are very similar to benign upper airway disease, and persisting signs and symptoms should prompt the clinician to look for more sinister pathology. Making the diagnosis of NKTL in resource-limited settings is challenging, as the diagnosis requires not only the demonstration of the NK cell markers, but also to have a positive aberration. The bigger centers need to collaborate with smaller centers in terms of facilitating the biopsies and potentially making these diagnoses. And unfortunately, mortality remains high in these patients, and we do need different cheaper regimens for the African setting. Thank you. These are my references.
Thank you very much, Matlasi, for such a well-researched and good talk. As this case is rare, I think we should go on to the next case and then take questions at the end, if that's okay with you, Vernon.
Is that okay? Can I carry on?
Yes, Linda, I think you can carry on. I don't know what happened, but I also got kicked out just now. But I'd like to introduce Lindo. I'm not saying your surname. Keep it to ourselves. On a rare case of hepatosplenomegaly, Linda is a specialist physician and is currently a fellow in clinical hematology at our center, and she started earlier this year. You can go ahead, Linda.
Okay, thanks, Dr. Philip. And for those who maybe would try attempt my surname, my name is Lindoruhle Kokwana. The click is not too hard, but Dr. Philip always shies away. As Dr. Philip has mentioned, I am a clinical hematology fellow at Chresani Baragwanath. I'd like to thank the previous speaker. Thank you, Matlati, for such a lovely talk. And I'd also like to thank the guys that organized the deep dive for such a lovely platform to be able to speak. I'm going to be presenting on a rare case of hepatosplenomegaly. The slides are, okay, here we go. So firstly, I would start by presenting my case where Ms. Pierce was a 31-year-old female. She was referred to the GIT clinic from a referring hospital and was admitted via GIT clinic to Ward 20. She was RVD reactive and virally suppressed. She had a 2 to 3 year history of this growing abdominal fullness that she kept seeking medical assistance for, with no definitive diagnosis that was made. She was previously treated empirically for tuberculosis based on her presenting symptoms, some of which were early satiety, significant weight loss, and drenching night sweats. She had no history of associated hematemesis, jaundice, or uremic symptoms. Her vital signs were normal on arrival. She had no lymphadenopathy, both in peripheral and central sites. On oral examination, there was nothing to write home about, and her abdominal examination revealed a massive splenomegaly at 21 centimeters, and this was measured from the midpoint of enlargement at the costal margin. It was firm, non-tender. It had a smooth surface. The notch was easily felt, and there was no splenic rub. She had a massive hepatomegaly of 12 centimeters below the costal margin, which also had a smooth surface. It was firm, non-tender, non-pulsatile, and no bruit was heard. Her cardiovascular, respiratory, and neurological examinations were unremarkable, but what was noted was that she had crops of petechiae on her trunk and legs. So these were her admission investigations, where we noted that she had a WHO grade 1 anemia. She had a grade 2 thrombocytopenia. The differential count revealed an absolute lymphocytosis and a population of other cells making up 61% of the cell count. As she was admitted from the GIT clinic, an array of workup for liver disease and portal hypertension was done to try and narrow the diagnosis, and all of these were within normal limits. And as we mentioned before, she was compliant on her ART and was virally suppressed with a CD4 count of 437, as noted below. Her peripheral blood smear showed rouleau formation and mild diffuse basophilia, but these other cells were described as small to intermediate in size with a high NC ratio. They had rounded nuclei with irregular contours. They were variably mature nuclear chromatin and indistinct nucleoli. The cytoplasm was scant and palely basophilic, and no Auer rods were noted. The platelets were decreased in number, as was noted in the previous slide, and no platelet clumping was observed, so it was a true thrombocytopenia. They then proceeded to do a CT scan on her, and the CT of the abdomen revealed a massive splenomegaly marked by the blue arrow, a massive hepatomegaly marked by the green arrow, and some ascites that you can also see there marked by the yellow arrow. This is a coronal view of the abdomen, where you can see the splenomegaly, the hepatomegaly, and the presence of ascites on the. So at this point, we then, scratched our heads and thought, what are the differentials for a massive splenomegaly? These include myeloproliferative disorders, including chronic myelogenous leukemia, primary myelofibrosis, and others. Lymphoproliferative, and of the lymphoproliferatives, these that would fall here with a massive splenomegaly is mantle cell lymphoma, hairy cell leukemia, prolymphocytic leukemia, extranodal marginal zone lymphoma, hepatosplenic T-cell lymphoma, large granular lymphocytic leukemia or lymphoma. Infective causes would be hyperreactive malarial splenomegaly syndrome, which we'd have to fulfill Kunle's criteria for, leishmaniasis, bilharzia. And others would include infiltrative disorders, storage diseases, and portal hypertension. The differentials for hepatosplenomegaly, which she had both, would be lymphoproliferative disorders, myeloproliferative disorders, infections, including bacterial, viral, fungal, and parasitic, chronic liver disease, connective tissue diseases, infiltrative disorders, chronic hemolytic diseases, and other. So we proceeded to do a bone marrow aspirate on the patient, and the aspirate revealed a hypercellular marrow, and this was due to a population of about 80% of other cells. These cells, as described on peripheral blood, were small to intermediate in size, with a high NC ratio, with an intermediately mature nuclear chromatin and indistinct nucleoli. The cytoplasm was scant and palely basophilic. These are the images attached of the hypercellular marrow, as you can see, and this is the population that we were looking at. On flow cytometry, it revealed a population of cells expressing CD2, CD3, CD7, and CD56 with dim gamma delta T cell expression. These cells were CD4 and CD8 negative. The trephine biopsy revealed a subtle infiltration by mature T cells. They were distributed intrasinusoidally, and a diagnosis of hepatosplenic T cell lymphoma was made based on both the marrow aspirate, peripheral blood, and flow cytometry result together with the trephine biopsy. This is just a diagram showing this monotonous T cell infiltrate that was noted. This is the CD3 staining. As you can see, it's in this intrasinusoidal pattern. And as I mentioned before, there was CD56 positive. This was also seen on immunohistochemical staining. We further did FISH for isochromosome 7q, which was negative. Trisomy 8 was negative, and she had a normal karyotype of 46XY. A liver biopsy was also done, and the liver biopsy unfortunately didn't definitively make a diagnosis of that we thought it would make, but they did mention that there was a T cell infiltrate that was noted in the sinusoid and mild feathery degeneration of the hepatocytes. As you can see, these T cells were CD3 positive. And in summary, I presented to you a case of Miss PS, who's a 31-year-old lady with a background history of HIV on combined antiretroviral therapy with no known history of opportunistic infections. She now presents with evidence and clinically and pathologically of hepatosplenic T-cell lymphoma, gamma delta type. She was stage 4B according to the Ann Arbor with the Cotswold modification. Her performance status was an ECOG of 1, and her prognostic index was 1 according to the International Peripheral T-cell lymphoma study, which was a low to intermediate risk. Just briefly on peripheral T-cell lymphomas before I speak about what I'm here to speak about. This is just a schematic diagram of the T-cell maturation. And in healthy adults, gamma delta T-cells, which is what we found here, make up less than 5% of circulating T cells and are commonly found in mucosal sites, lymphoid, and cutaneous tissues. They are more frequent in the spleen, where they contribute about 30% of the T cell population. They are derived from double negative thymic precursors, as noted above, and gamma delta T cells are part of the innate immunity because they have cytotoxic features. Peripheral T-cell lymphomas constitute about 15% or less than 50% of all non-Hodgkin's lymphomas, with peripheral T-cell lymphoma not otherwise specified being most common, followed by angioimmunoblastic T-cell lymphoma. Then if you don't divide your ALK positive, your anaplastic large into ALK positive and ALK negative, that then makes up the third most common. But extranodal NKT cell lymphoma then follows, and then adult T-cell leukemia lymphoma syndrome then will follow. This is a diagram that was taken from the ESMO Clinical Practice Guidelines on Diagnosis, Treatment, and Follow-up of Peripheral T-cell lymphomas, showing which of those are gamma delta T-cell type, including hepatosplenic T-cell lymphoma and some types of enteropathy-associated T-cell lymphoma type 2. So the reason, or my focus today, is on hepatosplenic T-cell lymphoma. I do think my title gave it away. Hepatosplenic T-cell lymphoma is a fairly new disease, first described in 1981, and was called gamma delta hepatosplenic T-cell lymphoma. In 1990, gamma delta was then dropped, and now it was now referred to hepatosplenic T-cell lymphoma, as rare cases of alpha beta phenotype were described. It was then in 1994, coinciding with the dawn of our democracy, that it was included as a provisional entity in the real classification. In 2017, Matthew McKinney and his colleagues undertook to do a whole exome sequencing on 68 patients with hepatosplenic T-cell lymphoma and uncovered a host of new genes that could actually be used for targeted therapy, but I'll speak about this later. And currently, to date in 2020, we have only about 200 cases described in the literature. So hepatosplenic T-cell lymphoma, the incidence is not particularly known. As I mentioned earlier, there are very few cases. It's thought to make up less than 1% of all non-Hodgkin's lymphomas and 1 to 2% of T/NK cell lymphomas. There are two types, I alluded to this, where the most common type is gamma delta T-cell type, and alpha beta type is the less common, makes up about 20%. It has a male predominance with a median age of 34 years. 72% are de novo, 18% are thought to be in immune compromised states, and 10% in inflammatory bowel disease. So to date, since 1996, more than 30 patients with inflammatory bowel disease have been reported to have hepatosplenic T-cell lymphoma. The risk factors of developing hepatosplenic T-cell lymphoma in patients with inflammatory bowel disease include male sex, younger age, the use of anti-TNFs, rather Crohn's rather than ulcerative colitis, and long-term thiopurine therapy. Post-transplant patients have a worse prognosis, and there's no data on the relationship with HIV. And as is with our patient, she was HIV positive. The clinical presentation, as was with our patient, they present with constitutional symptoms, abdominal discomfort due to the massive hepatosplenomegaly. They often have jaundice in severe cases. They do not have lymphadenopathy, and they often present with cytopenias, thrombocytopenia being the most important and is being always present and conferring an adverse prognosis. The cytopenias are often multifactorial in cause, including splenic sequestration, marrow infiltration, hemolytic anemia, immune-mediated destruction, and hemophagocytic syndromes. Abnormal lymphocytes in the peripheral blood are often noted, as was with our patient. Leukemic and blast evolution has been reported prior, and hemophagocytic syndromes may occur, as I've mentioned, and they often have a rapid decline. Pathologically, the morphology of the infiltrating cells is similar across all tissues, whether liver, bone marrow, or a spleen. These cells are monotonous, medium-sized lymphoid cells with round or slightly irregular nuclei with loosely dense chromatin. The nucleoli are small and distinct. They have moderate amount of cytoplasm, and their mitotic activity is generally low. The immunophenotype is CD2 positive, CD3 positive, CD7 positive, gamma delta T-cell receptor positive, and CD56 is positive in majority of cases. CD4 and CD8 are both negative with CD5 negativity. They derive from gamma delta T cells in 80% of the cases, and 20% are derived from alpha beta T cells. It involves the sinusoids of the spleen, liver, and bone marrow. And in the spleen, it shows red pulp expansion with white pulp effacement, with atypical lymphoid cells infiltrating the cords and the sinuses of the red pulp. In the liver, there's diffuse enlargement with no masses, as we saw on our CT scan. There's atypical lymphocytes that infiltrate the dilated sinusoids. Portal tracts and hepatocytes are generally uninvolved. The bone marrow is hypercellular with trilineage hyperplasia and large hyperlobulated megakaryocytes. Infiltration of sinusoids may be by atypical cells may be subtle and can only be appreciated, or sometimes can only be appreciated on staining of T cell antigens, as we saw with the images I showed before. Erythrophagocytosis may be prominent. The genetic profile is often that of the primary genetic event is that of an isochromosome 7q in 63% of the patients, with or without trisomy 8. Less commonly, we see 7q amplification, gain in chromosome 1q, loss of the Y chromosome, and loss of chromosome 10q. Recent whole exome sequencing of 68 patients revealed some changes in STAT5B and STAT3, that's the Janus kinase pathway, PIK3CD, and SET2 mutations. The diagnosis is often difficult and may mimic infectious causes of hepatosplenomegaly. And this was thought in our patient where she was treated for tuberculosis. She had a delay in her diagnosis, and as is with most patients, where it took about 2 to 3 years to get to the diagnosis. The diagnosis is often based on liver biopsy, bone marrow biopsy, or post-splenectomy. Demonstration of isochromosome 7q by cytogenetic testing is not necessary, but if it is found, it supports diagnosis. And often we move on to do some form of imaging, CT scan or PET-CT, to be able to appreciate the organomegaly. The differentials for hepatosplenic T cell lymphoma from a hematological point of view, we've already discussed the differentials for splenomegaly, would be that of a T cell large granular leukemia, where these patients have neutropenia, anemia, and splenomegaly. And what would be different is that the morphological findings in these patients will show large granular lymphocytes, and it also takes a sinusoidal pattern. Aggressive NK leukemia also presents with B symptoms, splenomegaly, cytopenia, but these patients have lymphadenopathy. Monomorphic epitheliotropic intestinal T cell lymphoma will present mainly with GI symptoms, and chronic EBV infection will present with B symptoms, cytopenia, splenomegaly, and lymphadenopathy. The prognosis of these patients, often people use the International Prognostic Index in most patients with peripheral T cell lymphoma. The utility of the IPI or prognostic indexes was actually discussed in the article listed below, where they found that the International Peripheral T Cell Project score seems to be the most important predictor of survival. This score includes age, performance status, and LDH. The other scores that were investigated included the prognostic index for T cell lymphomas and the modified prognostic index for T cell lymphomas. This just shows, as we mentioned, that our score was a score of 1, which showed a low to intermediate risk, giving us a 15% 5-year overall survival. So how do we manage patients with hepatosplenic T cell lymphoma? As with any patient with any disease, we do supportive management and specific management. And the supportive management would include education and management of management option discussions, blood and blood product support, the management of the patient's comorbidities, as was in our patient, using combined oral antiretroviral therapy, antibiotic support, and fluid and nutritional support. There are no randomized control trials for specific management for hepatosplenic T cell lymphoma. The management options are based on case reports mainly, and most therapies show no sustained response. So our best options are non-CHOP regimens followed by allo or auto stem cell transplant. Hyper-CVAD, platinum-based regimens, ifosfamide-based regimens, and cytarabine regimens seem to be superior to CHOP regimens. This is a table adapted from blood, where different case reports were looked at, where different regimens were used and their outcomes. And you can see that without stem cell transplant, the prognosis of these patients is fairly not that great. And now with exome sequencing, these patients, there's a possibility for targeted therapy, where we can, for the STAT5B and STAT3 mutations, ruxolitinib can be used. For IDH mutations, we could use IDH inhibitors, and hypomethylating agents could also be used. So this could be a place for newer therapies and better prognosis in these patients. So to speak about what we see at Chris Hani Baragwanath Hospital, in the period from 2004 to 2015, we had 52 patients with peripheral T-cell lymphomas, 30 females and 22 males. The female to male ratio was 1.4:1, with a median age of 46, with a range from 21 to 82. The T-cell NK lymphoid neoplasms accounted for about 7% of all lymphoid neoplasms, which is different from what is stated in the literature of about 15%. The most common subtypes, though, were very similar to what I described earlier on. This is courtesy of Dr. Omar, who did their MEd on peripheral T-cell lymphomas at Chris Hani Baragwanath Hospital. And particularly for hepatosplenic T-cell lymphoma, a case series was done by Dr. Philippa Ashmore. And this was a case of 3 patients that had hepatosplenic T-cell lymphoma at Chris Hani Baragwanath. Unfortunately, all of these patients demised with a mean survival of 7.5 months, but all 3 patients were HIV negative, unlike our patient who was HIV positive, with no other history or evidence of immunosuppression. So our patient was treated with 2 cycles of CHOP. We had no sustained response, and the spleen size went back to the original size by day 14. She then received 1 cycle of DHAP with no sustained response as well. Then she was changed to a modified hyper-CVAD regimen with etoposide. She had developed complications of the treatment, like with all our patients, with most patients. She's developed neutropenic fevers, nosocomial infections, but these have all been treated and she's survived thus far. Her current spleen size is 3 centimeters and her liver size is 3 centimeters. She's currently on her 7th cycle of this regimen. We do not have an HLA matched donor, but she's likely for a transplant once remission is fully achieved. This is how we divide our regimen, where we, on cycles 1, 3, 5, and 7, we give cyclophosphamide, adriamycin, vincristine, dexamethasone, and etoposide. And on cycles 2, 4, 6, and 8, methotrexate, cytarabine, and prednisone, where we give hyperfractionated cyclophosphamide. So in conclusion, this is a rare condition where we've only had 5 cases to date at Chris Hani Baragwanath. I've mentioned 4 cases because unfortunately the 4th or the 5th case recently demised. He was also on a hyper-CVAD etoposide regimen. It's difficult to treat with poor outcomes. There's no data on its association with HIV, and it is unclear how to best treat this patient. But however, we have started on a hyper-CVAD regimen, and it appears to have conferred a good partial response and has shown stabilization of her disease. And this will need to be followed up with consolidation with an auto stem cell transplant. I'd like to acknowledge the Chris Hani Baragwanath team and the NHLS and the patients who always trust us at their most vulnerable times. Thank you very much.
Thank you very much, Linda, for a very extensive talk and thorough. I'd like to ask if there are any questions from anybody. I can't see any cases at the moment.
Anita, if I can start while we wait for other questions. So I just have one comment and maybe or 2 comments perhaps on the first presentation. First, I want to say thank you very much to both speakers for excellent presentations. I thought it was really insightful and very, very useful. My first comment relates to the staging of NKT cell lymphoma. And I think on a cautionary note, the TNM classification system that was suggested by the the group published under Yan in 2015. What we have to remember about that publication is that it was based on a retrospective analysis of a case series with extremely variable treatments being used. And they suggested in their paper that this should be validated by a multi-center collaboration, and that hasn't happened yet. So for that reason, at this moment, although we're still looking for an ideal staging system, the Lugano modification of the Ann Arbor is still being recommended, even in the 2020 NCCN guidelines. There are other suggestions based on the very important role of the invasiveness, the local invasiveness of the tumor. Another staging system has also been suggested, which takes that into account, and the exact detail of the invasiveness. Once again, we haven't got, that's not validated yet, so not in wide usage. And then I might have missed it, but I'm not sure if you mentioned, did you mention the PINK or PINK-E prognostic scoring system?
No, Prof. Lo, I didn't.
Okay, so just to make everyone aware, there is something called PINK, Prognostic Index for NK cell lymphoma, or and then there's also the PINK-E. So the PINK takes into account age over 60, stage 3 or 4, distant lymph node involvement, and non-nasal type disease. That would be PINK. And if you, like was mentioned, if you have the Epstein-Barr virus measured EBV DNA in the peripheral blood, that becomes an additional marker for the PINK-E. So it's two systems. The one is if you have the EBV DNA available, and the other one is if you don't. I see there's a question in the, there's a question here from Moses Charambutsa, Vanita. I don't know if you want to take it.
Thank you. Yes, thanks for your comments, Vernon. Moses asks if in those patients with hepatosplenic lymphoma and sequencing showing the mutations like STAT5 and JAK2, do you use the agents alone like ruxolitinib or combine with chemotherapy? Would you like to answer, Linda?
Because there's such little evidence, I think you'd be really brave to use them alone. But I think probably you would use them in conjunction with chemotherapy. Unfortunately, there is no evidence I didn't find any papers of people that have used this targeted therapy alone on its own, and this is anecdotal completely.
I agree with you on what you have said. As the number of cases are so few, I don't think we have enough knowledge to know whether to add or to use it separately. But we definitely at Barra do not have access to ruxolitinib. We don't even have access to hypomethylating agents. So at this moment, we have to treat with what is currently available. So I would, if I had the choice, I think I would still combine with chemotherapy. The few patients we've had, the outcomes being very poor, and I think it's because disease progresses quite rapidly and we don't seem to manage to get a hold on the splenomegaly or the counts. And from what I remember, all our patients demised within the first 6 to 7 months of coming to us. I think Johnny has put up his hand. Would you like to ask your question, please, Johnny?
Certainly. Thanks very much to both Mahlatse and Linda Hohle for these very well-researched case studies and review of the literature. I think, in fact, you should publish this. I think it's very educational. My comment largely reflects around Mahlatse's presentation. I mean, we don't see a lot of these cases around. Do you think that part of the reason we don't is because of the confusion of this presentation with extrapulmonary TB? Is it possible that some patients get treated for extrapulmonary TB and then therefore these cases in fact are missed? That's the first question. The second question relates to, I just noticed that the hemoglobin was 8.5 and as you correctly pointed out, the LDH was raised. And perhaps for the benefit of the registrars here, did you exclude a hemolytic process? And I'm sure you did, but it's important that in fact, at least the registrars would understand the thinking behind it, that one would want to exclude other things that cause that combination. And then the last question, Mahlatse, is maybe you could comment on giving systemic chemotherapy to a localized disease such as the one that you presented.
Thanks, Prof. Mahlangu, for the questions. Most definitely, these patients can be confused with other disease processes like TB. I think that the point to take home here probably is the role of histology. So, always biopsying these lesions and sending them for histologies, the stains and the markers. That's probably the best way that we would end up not missing some of these cases. With regards to your second question, Prof. Mahlangu, we did exclude a hemolytic process. There was a smear that was done that didn't show much really in terms of spherocytes. The last question, if you can remind me, Prof, that the last question?
And again, this is purely for the registrars. Why do we give systemic chemotherapy to localized disease such as this one?
Oh, so definitely the tumor itself is very radiosensitive. So there's no question that they respond very nicely to radiotherapy. However, in some of the studies that I showed in the presentation there, it's been shown that adding systemic chemotherapy in addition to the radiotherapy, these patients do better. So it's thus recommended that chemoradiation be the treatment modality for these patients. Dr. Philip, I don't know if you'd like to add in terms of my response to Prof. Mahlangu's questions.
Yes, I would like to. And with regards to the chemotherapy, radiation therapy to the head is very good, but unfortunately they sometimes have to attenuate doses because of trying to protect the brain tissue and surrounding tissues there. And you could easily miss some of the tumor, and as it spreads so fast, we should be giving systemic therapy to all these patients. And my understanding is in lymphomas, other than Hodgkin lymphoma, you cannot, even Hodgkin nowadays, you cannot get away with just radiation therapy. It's always advised to give systemic therapy to all these patients. There's one more question from Garrick. Did any of your patients have any biochemical features to suggest HLH?
I can confidently say that my patient did not. Matlati?
Yeah, our patient also didn't have much in the way of HLH, in terms of biochemical as well as clinically. There was never really much to say the patients had HLH.
Actually, from all our 5 cases, I don't think we've seen features of HLH on any of our patients. I know it's possible and we look for it, but we haven't picked them up yet. There's another question from Nolu. Thanks for a great talk. Linda, you said your case repeatedly presented to the hospital. Were the lymphoma cells not present initially on the smear?
So to answer that, Nolu, thanks for the question. I cannot speak for what happened prior to her arriving at Chris Hani Baragwanath, but even how we as hematology heard wind of her is that the lab picked up these abnormal cells. And initially the thought was, oh my gosh, this is a patient with some leukemia. So even when we went to go see her, but her spleen was massive, there was the differential that this could be acute lymphoblastic leukemia, but it turned out to be hepatosplenic T-cell lymphoma. And she was fairly well otherwise.
If I could just add a comment there, I have noticed that in the peripheral hospitals, differential counts are not often done, and actually doctors do sometimes ignore counts when they're very high. I think they don't understand. They just assume that it's a neutrophilia from infection. So that's probably why she was also missed in the peripheral hospitals. And then there's another question from Vernon. Is anyone using splenic biopsies for otherwise unexplained splenomegaly? No nodes, normal marrow. Please comment in the chat. We are definitely not using splenic biopsies for unexplained splenomegaly if we think it is indicated and we have excluded portal hypertension and there is significant cytopenias, we would do a splenectomy, but not a splenic biopsy. I'm not sure if you, Vernon, do splenic biopsies.
Yeah, so thank you, Vanita. Yes, we do. We also used to do splenectomies in the past in these cases, but in Panorama Mediclinic, the while that I was in private practice, there was one of the radiologists there learned how to do this in the States, and I did it on one patient. It was very helpful, and now we've been fortunate enough that the team at UCT Radiology can do it as well. They've done 3 cases so far. One case, unfortunately, the patient did have a bleed. They didn't recognize it as a bleed, even though our team told them it's probably the drop in HB is due to a bleed. But I think everyone has learned their lesson now. Patient didn't have any sequelae afterwards, but again, very helpful. And they do it with a special technique where they, what's the word, stopgap, or that they do this biopsy under CT guidance or sonar guidance, and then they can plug the biopsy tract afterwards. So and you get a good call, so it could be very helpful. You save the spleen, you save that part of the immunity for the patient, and you can get very good histology. I see Garrick Lorden has done it. Garrick, what did you do? How did you do it? Did you do it yourself, or did the radiologists do it? Prof. Peter Levey at Kalafong with a true cut biopsy. Interesting. But I think you need to have your surgeons on standby. Everybody need to be on board. If there is a bleed, then the patient does need a immediate splenectomy. So patients should still be vaccinated before and ready, nil per mouth, ready for splenectomy if need be. But can be very, very useful. We've not had to do a splenectomy on the first 4 cases.
Thanks for the suggestion. We must actually bring it up with our radiology department, because we tend to wait and see if this patient will progress, and we can then make the diagnosis on a lymph node biopsy, or if there's peripheral spillover or something. Johnny, do you still have a question? Your hand is still up. Thank you. There are no further questions, and like our speakers were saying, we have really very few cases. This was our first case of a nasal NK cell tumor. I'm not sure if any of the other centers have any cases, seen patients, and yes, we've had now 5 cases of hepatosplenic T-cell lymphoma. But they are rare, and I think this was a learning opportunity for everybody to manage patients. I don't think we've got a true handle on which the best treatment modalities are. Our patient currently is doing well, and I'm hoping that we can take her into transplant early in the year once she's finished her 8th cycle.
Well, with that, great. Thank you very much, Vanita and team. That's really fantastic. I think it's a great way to end the year. And I want to also just thank the VITS team for excellent sessions during the year. It's been really, really great. And I want to say thank you to every division and department around the country who's been so positive and engaging and doing this enthusiastically to the benefit of all. I think it has brought all of us much closer together as a larger team. I'm very excited about the future for hematology in the country. Things seem to be happening at a rapid speed in all directions. Number of people who want to subspecialize, funding coming available for research, for education, opportunities for all of us. It's just the best time ever, I think, to be in hematology in South Africa. So I'd like to just remind all of you to, let me just see, Estelle, are you still here? Yes, I think Estelle will probably just add the link for the CPD points in the chat. I don't see it there yet. Then you can just register for your attendance for today. A reminder again that you can email Melanie Davids. I'm just typing it into the chat box, who will on an individual basis provide you with your CPD certificates. It's not sent out routinely, so only for those who need it, please email her because it's being done manually. We will reconvene on the 17th of January. So we're taking a break of a month with the holidays coming up. So please make a note in your diary so long, but in due time, emails will follow with speakers and topics, etc. And we look forward to having all of you on the podium at some stage next year. So once again, a big, big thank you for your attendance, for your contributions, to Vanita, to the team today, Mahlatse, to Lindo, for your wonderful inputs. And we see you again soon. Bye-bye.
Thank you all, and have a wonderful festive season.
Thank
Bye.
you very much.
Yeah, thank you, VITS team. And my excuse